Good morning, everyone. It is my absolute pleasure to introduce Catherine Wisner. She is the Normal and Helen Asher Professor of Psychiatry and Obstetrics and Gynecology and the Director of the Asher Center for Research and Treatment of Depressive Disorders at Northwestern University, Feinberg School of Medicine, Department of Psychiatry. Dr. Wisner is board certified in general and child and adolescent psychiatry and is a pioneer in perinatal psychiatry. Her research has advanced our understanding of the natural history of mood disorders across childbearing, benefit-harm decision-making for pharmacotherapy during pregnancy and lactation, and the pharmacokinetics of medications across pregnancy and lactation. She is internationally recognized as an expert in the treatment of mood disorders during pregnancy and the postpartum period. Dr. Wisner has received over $21 million from NIH across her career and has 250 peer-reviewed publications. Thus, her work has incredibly far-reaching influence and has, as she had been cited by authors in more than 90 countries. Please help me in welcoming Dr. Catherine Wisner.
It is such a great pleasure to be back in Pittsburgh today to speak with you about mitigating maternal melancholy. When I give this type of talk, one of the things that concerns me is that I'm not really conveying the pain that my depressed patients experience. So I brought some quotes from them to tell you more about what it feels like. One of my patients said, "I was so concerned about losing my body that I never even considered that I would lose my mind." Then a poem, "You say that I'm depressed. I wonder if you understand. You've never lived, I think, in this God-forsaken land. I always fight to function. I'm fighting to survive. I'm trying desperately to remember what it's like to feel alive. You say I'm carrying life inside. How can that really be? How could life possibly survive in a non-existent me?" So this is an illness that takes away the positive emotions that help us cope with life, with things that happen. And it is a physiologic dysregulation illness, so the circadian rhythms we just heard about are dysregulated. Women have trouble with sleep, appetite, concentration, and again, left with only painful emotions. What I'll talk about today is the incredible problem that we have in terms of public health, how common maternal mood disorders are. What do we know about antidepressant treatment, given that women of reproductive age are at very high risk for mood and anxiety disorders? I'll also talk about our societal protectionism of pregnant women and how it's contributing to poor guidelines, lack of guidelines about how to treat these patients. And finally, what can we do to improve our care? I did a study when I was in Pittsburgh, and at Magee-Womens Hospital, I screened 10,000 newly delivered women at 4 to 6 weeks after birth with a standard depression screen, the Edinburgh Postnatal Depression Scale. I asked these women when was the onset of the illness that we were identifying at 4 to 6 weeks postpartum. Women said, about a third of them said, this illness began in pregnancy. That's 9 months. 40% of those women said this illness began in the first 4 to 6 weeks since I had the baby. So again, this burst of cases postpartum that we know exists from epidemiologic studies. And finally, a quarter of those women said, I've had this chronically. 25% of those women again said, I've had this even before pregnancy. So this translates into screening guidelines that compel us to screen during pregnancy as well as, and particularly importantly, in that post-birth period. We also know that maternal mental health is critical for healthy pregnancy outcomes. That's a theme of this conference. And in 2017, my OBGYN colleagues and a group of us in mental health put together this document, which is a guidance for identifying, screening, identifying, and treating women with depression in obstetrical practice because it's recognized as a significant patient safety issue. All of the outcomes that we are concerned about, that we've been talking about. The adverse outcomes of pregnancy are more common in women with depression. And we also worry about when the baby is born, what kind of regulation could a mom who is so overwhelmed that she can't regulate her own emotions, how is she to regulate that infant's emotion? Because the primary caretaker's task is really to, when an infant is dysregulated, distressed, to move that infant towards sleep or more awake, alert, comfortable. If she can't regulate her own emotions, she can't do that. And attachment problems and childhood behavioral problems are well known to be associated with maternal depression. We have an unacceptable rate of maternal morbidity and mortality in that first postpartum year. And if we look at what are preventable causes that we might address to reduce this, again, unacceptable and embarrassing risk we have in America, one of the contributors is this: maternal mental health conditions, overdoses, suicides, and although it's not a mental health condition per se, homicides add into this difficult and, again, embarrassing and unacceptable rate of maternal mortality. And this speaks to identifying and treating these illnesses in that early postpartum period. How far have we come in our treatment of depressed women? So my colleague Kate Sticka wrote a book chapter about treating pregnant women with antidepressants in 2001. And I love this quote: "The pregnant woman is perhaps the last true therapeutic orphan because of all of the ethical, medical, legal, and safety concerns that we have been talking about, particularly yesterday in this conference. Few pharmacokinetic, pharmacodynamic, or clinical trial studies are done." We've made progress in terms of attending to this issue. So the trans-government-wide PregLact task force, so a task force to look at pregnancy and lactation and what are the research gaps, what do we need to do to better care for pregnant women, not only for depression, but overall. Those recommendations and guidances, which includes getting away from viewing pregnant women as vulnerable, but as a group in need of research, decreasing regulatory rules, regulatory difficulties that create problems for advancing research, excuse me, in pregnant women. And so here we are in 2021, in the title of this article in JAMA, "Pregnant People's Paradox: Excluded from Vaccine Trials Despite Having a Higher Risk of COVID-19 Complications." 20 years later, we are still struggling with the same issues. And I think we need to adopt this mantra: protect women through research, not from it. In trying to make the case to say we need to do this research, I wrote an article last year to use the principles of medical ethics to argue that women were not being served in an ethical manner in terms of research. So the 4 principles are non-maleficence. In other words, do no harm. I have heard so many of my colleagues say, I am not going to treat this woman with medication because my rule is do no harm. And yet, of course, what that leaves out is, what is the harm that is done by not treating? Maternal suicide is a very bad outcome. What about beneficence? Do we have the obligation to advance pharmacological care for pregnant women? What about respect for autonomy? Does the pregnant woman get to decide what research she will participate in? Or is that boundary made by a governing body? And who decides what those boundaries are? And justice. What about fair distribution of benefits, risks, and costs that are inherent in research across the population? Well, it certainly isn't true for pregnant women. And the inadequate data that we have to determine benefits and harms in pregnant women, I've been in this business for now 3 decades, and I really am tired of saying to pregnant women, well, you know, we know this much, but we have so much we don't know. And many of the women who participate in my studies say they're participating because they want there to be data for their daughters if they face the same problems. So what do we know about antidepressant use in pregnancy? Over these decades, what we've struggled with, because we can't do randomized trials, we're looking at observational studies, is this problem of trying to associate a medication, say an antidepressant, with the risk for birth defects. So for depression, this is incredibly complicated because, of course, you don't use an antidepressant unless a woman has an underlying psychiatric disease. And that psychiatric disease comes with so many other variables that are confounding variables that also affect the outcomes. And recently, what has been helpful is the application of more advanced statistical techniques to this problem. And this is a classic study by Krista Hybrex and her colleagues at Harvard. And what she uses is the Medicaid database. So nearly 1 million women. She evaluated those women exposed in the first trimester to SSRI antidepressants and those who weren't exposed. And what she did is, I think, very telling. If you ask that question, what is the risk of cardiac defects in women who take SSRIs in pregnancy compared to women who don't? You get about a 25% elevation in risk in the SSRI treated, the offspring of those moms who were treated with SSRIs. If you then say, I'm only going to limit my comparison groups to women with depression who took an SSRI and women with depression who didn't take an SSRI, so making the groups more equal in terms of diagnosis, that risk goes down to 12%. So it's not significant. If you then do propensity score matching, which is simplistically, it's bringing in those confounding variables to again adjust your analyses. It would be like taking a woman with major depression who took an SSRI who was obese, which we know is related to birth defects, compared to a woman with major depression who didn't take the SSRI, who's also obese. It's a way to even out some of these confounding factors. And repeatedly in Dr. Hybrex's work, when she does these statistical analyses, the relationship between antidepressants, the SSRIs in particular, and cardiac defects becomes not significant. So one of the exciting areas for me is asking this question, might medications improve outcomes? Now, if you treat pregnant women and you treat them with medications, you wouldn't give the drug unless you thought that you were doing that maternal fetal pair some good, that you were reducing the disease state, that would be important. But if you go to the literature and say, well, where are the studies that show that if you treat, the outcomes are better? They weren't there for a long time. And now some of those studies are beginning to emerge. So in this large-scale Scandinavian study, what the investigator did was look at antidepressant-treated women with psychiatric illness or women with psychiatric illnesses who weren't treated in this large population. And they looked at preterm birth and found this, I think, somewhat astounding 48% reduction in very preterm birth and a 30% reduction in cesarean sections. Now that is astounding, and this hasn't been replicated. And one of the hypotheses, if this is true, one of the hypotheses I would entertain is that they are particularly good at treating depressed women in Scandinavia to remission. That is, they're really good at removing what is removable with medication treatment from all those confounding variables, and the outcomes are improved. Unfortunately, like the vast majority of studies in my field, nobody reports symptom data. And it's particularly hard in a large-scale epidemiologic study, but that's what we need to know, and we do not know that yet. There's also another study that it's an animal study in which treatment of a dam with antidepressants was compared to non-treatment in a model of very stressed animals. And there was an indication that some of the adverse effects of stress on the fetal brain was potentially that the brain might be protected from damage due to stress. What about antidepressants and development? There's no evidence that antidepressant exposure in fetal life creates a difficulty in terms of neurodevelopmental problems, and there will be a major paper coming out about this issue soon. I like the theme of fathers matter too. In this study is a really interesting investigation in which, again, a Scandinavian investigator looked at women who took antidepressants in pregnancy compared to those who didn't, and looked at was the risk of early onset affective disorder greater in adolescents in their offspring. And yes, it was 20% higher. But what she also did then was look at the same analysis in fathers. So the fathers of those pregnant women were evaluated for, did they continue antidepressants or discontinue them during their partner's pregnancy? And the interesting finding was that yes, if the fathers continued their antidepressant treatment, that the risk for early onset adolescent affective disorder was 29% higher. So a very similar risk, again pointing to parental psychopathology, other factors rather than medication. So we know that medications affect the fetus and the brain. Depression, stress affect the fetus and the brain, but probably in very different ways in different dyads. And there are some fMRI studies to show that perhaps the neonatal functional brain organization is different based on those exposures, without making judgments about is that good or bad. It's different. In fact, one of my colleagues has shown that SSRI exposure increases connections to the parts of the brain that process auditory inputs, and that those babies are better earlier in infancy at distinguishing non-native speakers in their home. But what we really want to do is treat women optimally, treat them to remission. So, because that's really what justifies drug treatment, but we don't know how to do that. So the problem is that the physiology of pregnancy changes dramatically. And we just finished a study in which we asked the question, are this group of patients who decided to take their medication during pregnancy because it was useful, they really could not function without it, what we found was about a third of these women had depression scores that were close to those indicating major depression. So we have a lot of partially treated patients there. Why is that? We then conducted a series of studies to look at, do concentrations of drugs change across pregnancy? And the answer is, for many women, yes. So this is fluoxetine, and you can see for this long half-life drug, relatively stable till 36 weeks to delivery. This is sertraline, shorter half-life drug, from 20 weeks to delivery on average comes down substantially. Same is true for citalopram and its metabolites. So the enzyme systems, the cytochrome P450 enzyme systems, also change their activities. Most of them increase in pregnancy. The clearance goes up, and these drug levels go down. So if the woman needs a level here to be responsive, she's at risk for depression. So just two comments about what we can do to improve care for women. A big problem is there isn't enough mental health services, and the pandemic has really contributed to that. So with Emily Miller, who is an MFM in our group, we adapted collaborative care, which is usually designed for primary care, to incorporate mental health care into a practice setting. We adapted that for obstetrics. So we've screened about 3,000 women. They're monitored across time. The team consists of a social worker, care manager interacting with the patient, the obstetrician, the psychiatrist. Psychiatrists actually are psychiatry fellow trainees who staff this clinic. And what we've seen is that the amount of screening has gone up, the number of recommendations for treatment and actual access to treatment has gone up with this model. The other issue I wanted to talk about briefly is fathers. So one of my faculty members made the case that we see our patients for therapy maybe once a week at most. He made the case that the partners of these moms that we see with depression are out there available, they need information. So he just got funded to study a 6-module intervention for the partners of women with depression. And it's a really fascinating set of educational materials and actual participation. So They talk about what is depression, how can he or the partner help this woman to cope, what do they need to do to prepare for pregnancy, how are they going to negotiate who's doing what. And I opened my closet at our suite recently, and a bunch of diapers fell out, and I didn't know what that was for. And Dr. Fisher said, well, that's for the diapering that we're going to do to show the dads how to do diapering. So that's quite fun. And I'm going to skip to my final slide here. A couple days ago, Women's Health Access Mattered published an interesting study about that if there were a $300 million investment in women's health, that it would yield $13 billion in return for a number of reasons. And that's just a fascinating set of numbers. And another thing that I really am concerned about is that our societal protectionism appears to end when the cord is cut. So here we are in America with no federally mandated paid parental leave in a very wealthy country. And 55% of our moms live in poverty. So my conclusion is we must adopt our therapeutically and socially orphaned pregnant people into the mainstream of healthcare research, practice, and policy. Thank you.